I have no financial disclosures to report. However, I am from Canada. And as a result, this is how I see the United States. I'm a diehard Leafs fan living in Boston, and I think the beaver is a proud and noble animal. So today we're going to talk about pediatric orthopedic emergencies, and the first objective is really to recognize how kids are different from adults from an orthopedic perspective. And what I hope is at the end of this hour you'll be able to recognize the pediatric orthopedic emergencies that can present to your clinic, including fractures, limps, and other problems. And finally, identify a few snakes in the grass, as there exist quite a few in pediatric orthopedics. First, I'm going to present the top 10 differences between kids and adults, according to me. So one, children have growth plates or physes, and that's different than adults. They have a thick periosteum that wraps around the bone. They bend before they break when they have an injury. And they heal very quickly, thankfully for us. They have tremendous remodeling potential. They have overgrowth potential as well. Their joints are resilient and can tolerate long periods of immobilization. And that looking at physeal fractures can be confusing even for a trained orthopedic surgeon and radiologist. And we should always consider non-accidental injury in children who are non-ambulatory. And the top 10 difference between kids and adults is that kids have parents, and we all know we have to deal with those. So in particular, the growth plate. The growth plate seems to be an area of concern for parents whenever their child has a fracture. And what you can see from this slide is that physeal fractures can occur at all ages of children, but definitely have a peak between the ages of 11 and 12. And physeal injury can happen from direct trauma, usually from shearing or malalignment, but also can be resulted from ischemia and trauma to the ring of Ranvier. And the way to think about the physis is egg foam. And really the two pieces of the physis are two interdigitating pieces of egg foam together. And once a fracture has occurred, the pieces of the egg foam have been split apart. And the goal with reducing the fracture is to try and put the egg foam back together so the interdigitations match up. And when those interdigitations don't match up, we have a growth arrest. And when we think about growth plate injuries, the Salter-Harris classification is the most commonly used classification system. And if you think about the mnemonic of Salter, it can help you remember where the fractures lie. Where S is straight across the physis as a Salter-Harris 1 fracture, A is above the fracture or above the physis, L is below the physis, T, or Salter-Harris 4 fracture, is straight through the physis, and Salter-Harris 5 and 6 fractures involve a crush through the physis. So our second difference is that children have a thick and strong periosteum. And really the periosteum is the covering around the bone, and the analogy is it's like the bark on a tree. It helps us in being an internal cast for fractures, but we have to manage the periosteum when we're trying to reduce a fracture. And the best way to think about periosteum is the analogy that a child is a branch on a living tree. And when you try and pull that branch off of the living tree, it doesn't just snap, but it splinters and cracks. The difference would be you or I, who are old, are the branch that's already on the ground. And when we bend that branch, it just snaps, because our periosteum is much thinner. So although periosteum is thick and strong and that's helpful, it can also be a problem. Sometimes when the fractures are displaced, it can get stuck in the joint, leading to an irreducible physeal fracture, as seen here based on the gap in the X-ray. The third difference to think about is that a child, when they have an injury, bend before they break, and they get what's called a Greenstick fracture. This seems to be much more common in children under 8, and what happens is the bone breaks before it bends. The fourth difference is that children heal quickly and readily. This slide shows from day 1 to day 6 of a traumatic humeral shaft fracture, and what you can see is the tremendous remodeling potential that happens, so that at 6 months you can't tell that a fracture ever occurred. Non-union is rare in children, and the younger the child is when they have the fracture, the decrease their immobilization time. It's important to recognize, though, that bone healing is different depending on where the fracture has occurred. So if you have a child that has a fracture near the growth plate, in the metaphysis or epiphysis, that fracture will heal quite quickly, and you should refer them to a pediatric orthopedic surgeon within 7 days. After 7 days, the fracture's already started to heal. While if you have a fracture in the diaphysis, which is in the mid-shaft of the bone, the healing takes much longer. In general, most children are casted for their injuries between 4 and 6 weeks. Children also have a tremendous remodeling potential, and this remodeling potential is directly related to the age of the child. This helps us as orthopedic surgeons because anatomic reduction is not always necessary. Through a process called Wolff's Law, bone will remodel as growth continues based on the forces applied. And as you can see in this slide, there was at least 35 to 40 degrees of angulation that's already remodeled in 6 months to less than 20 degrees. So we can accept some imperfection. The greatest amount of remodeling tends to occur near joints, in the plane of motion, and in younger children. Children also have an overgrowth potential related to their remodeling. And there are certain parts of the body when they have a fracture tend to overgrow. The most common is the femur, where in children between the ages of 2 and 4 who have femoral shaft fractures have an overgrowth phenomenon as the bone begins to heal. And as a result of this, sometimes we allow for some shortening when we set the bone to accommodate for this overgrowth. Other areas where this can happen is the tibia, where you can get what's called a Cosin deformity, as seen here on the picture, where the bone heals and overgrows, creating a valgus-type deformity. And in the elbow, a similar phenomenon occurs at the lateral condyle, creating a varus appearance or a gunstock appearance to the elbow. Children have resilient joints. Stiffness is not as much of a problem as it is in adults, and as a result, we immobilize children for a longer period of time to ensure that healing occurs. The emphasis is on long-term anatomic result, not early function and mobilization. Now, we all know that children's x-rays can be very confusing, primarily because there's many anatomic variants and many developmental stages that a child goes through. When in doubt, consider a comparison view of the unaffected arm, or call a friend who has more experience. This is an example of a transcondylar physeal separation. This happens in young children, usually under the age of 1. The challenge here is that the majority of the X-ray is cartilaginous, and because of that, you cannot see it on the plain radiograph. So you have to use indirect techniques to assess the reduction. And you should always have a great suspicion when you see a swollen limb with no obvious fracture. Children under 2 should not have a fracture, and when they present with a fracture, you have to think about non-accidental trauma. 33% of all non-accidental trauma is seen first by an orthopedic pediatric surgeon. So you should have an increased suspicion, in particular when the story is unclear, changing, or doesn't really make sense with the mechanism of injury you're seeing. If you see multiple fractures in various stages of healing, that should also increase your suspicion. NAI is treated with a multidiscipline approach and involves care of multi-providers. Now, some of the high-risk patterns of non-accidental injury involve the metaphyseal bucket handle fracture, as seen on the far side, the posterior rib fracture, scapular fractures, as well as spinous process fractures. And finally, children are different from parents because they have parents. And we have to deal with their parents because fractures and injuries to their growing child create a ton of anxiety. So managing the parent will make it much easier for you to manage the child. So now that we've talked about the 10 differences between children and adults, we're going to talk about the main can't-miss emergencies that I think you have to come away with knowing about. So first, we're going to talk about compartment syndrome. We're then going to talk about open fractures. And then through a series of clinical vignettes, we'll talk about slip capital femoral epiphysis and septic arthritis. So compartment syndrome, what is it? Compartment syndrome is a scenario where there's increased pressure within an enclosed compartment. This disrupts the normal oxygenation that's occurring in the leg, and what happens is we start to see ischemia. There's a lack of oxygenation that occurs in that compartment, which eventually leads to muscle death and nerve death. The number one cause of compartment syndrome is a fracture or a crush injury. But there are other causes that more commonly would present to a clinical setting. such as infection, extravasation, or a dog bite. What you need to look for is a swollen, tense limb, and it's a challenging diagnosis in children. But what you have to realize is this is a true emergency. How do you make the diagnosis? People say it's the P's of compartment syndrome: pain out of proportion to the injury, pain with passive stretch, paresthesias, paralysis, and pulselessness. But really, if you think about all of those signs and symptoms, the most important is pain out of proportion and pain with passive stretch. As you start to look for paresthesias, paralysis, and pulselessness, you've missed the boat and the compartment syndrome has been going on for too long. So have an increased suspicion in high-energy injuries, primarily in the forearm and in the tibia. And when you see a compartment syndrome, you need to refer early. First, loosen any tight dressings that exist on the patient, because the first 6 hours is our golden window. In these 6 hours, we need to decompress the tight area to allow for repeat oxygenation to the muscle and nerve. Muscle and nerve ischemia begins after 6 hours, and at that point, it's usually irreversible. The only treatment for compartment syndrome is surgical decompression, and often we have to leave the wound open and let the swelling settle down. Open fractures. One must always be aware of an open fracture. Usually in the clinical setting, it will be a fall with a fairly innocuous abrasion, maybe over an area of swelling in the setting of a fracture. The key hallmarks to this abrasion or small wound is that it continues to ooze blood. The parents will say, we put a dressing on it, but it's already bled through. The emergency room will say, it's not stopping, it keeps bleeding. Sometimes if you look at it, you may see a little bit of fat tissue. But these are the signs that there's been a puncture from the bone from inside out. And the risk is this is associated with infection. So be suspicious if you have a grossly displaced fracture with an associated abrasion or puncture wound, or if on the x-ray you see something that looks like air. The management of open fractures involves splinting, checking if the tetanus is up to date, starting some antibiotics, and sending the patient somewhere where they can get definitive treatment. So now we've talked about compartment syndrome and open fractures, and we're going to delve now into some of the common clinical scenarios that present to a primary care or pediatrician's office. So the clinical scenarios we're going to talk about is the child presenting following upper extremity trauma, refusing to use their arm, a toddler or child presenting with limp, refusing to bear weight, a child and adolescent with hip pain, and one with knee pain. So before we get into those clinical scenarios, I think it's important to brush up on our musculoskeletal imaging. This slide really just goes over what are the best modalities for what you're looking for. So clearly X-ray is the mainstay. We usually try and get at least two what are called orthogonal views, which are views that are perpendicular to each other, so that if there is a fracture or an abnormality on the X-ray, you see it on both planes of view, so that it's truly a lesion as opposed to something that's factitious only seen on one plane. The CT scan is commonly used in adults, not as commonly used in children just because of the risk of radiation, but gives us the greatest detail in bone. MRI, on the other hand, is used for skin, soft tissue, cartilage, and fluid, and doesn't give us the greatest detail on bone. We use ultrasound commonly to look at possible foreign bodies, fluid in a joint, or soft tissue. It's very helpful for guiding us if we have to aspirate a joint or a fluid collection. And finally, the bone scan, or DEXA scan, is used to test if there's an area of increased osteoblastic activity or inflammation. It's not used as commonly now because of a high dose of radiation associated with it, and more commonly we're using CT and MRI. However, there still is utility for bone scan, and I like to think of it as the needle in the haystack test, because it will look through the whole body to find an area of inflammation or osteoblastic activity. So going back to our clinical scenarios, the first scenario we'll talk about is the child presenting following upper extremity trauma, refusing to use the arm. So when you think about upper extremity trauma, it's a pretty wide diagnosis, a pretty wide differential diagnosis. But looking around the elbow in particular, acute injuries can be a supracondylar fracture, a lateral condylar fracture, a medial epicondyle fracture, a forearm fracture, a radial neck fracture, a Monteggia fracture, or a nursemaid's elbow. So the diagnosis is fairly extensive, and that's not even looking at shoulder injuries or the majority of wrist injuries. So these are the things to think about when a child presents to your clinic with a sore elbow. And just to review some of the bony anatomy, if you think about the areas of where you can have an injury, the supracondylar area is at the top. The medial epicondyle is on the inside part of the elbow, in continuity almost with the ulna. The lateral condyle is opposite of the radial head on the lateral aspect of the elbow. And by far and away on the lateral, this is the weakest part of the elbow, which is called the supracondylar region. So our first case is a 3-year-old girl found crying in the living room after playing Superman on the couch with the older sibling. She's refusing to use her left arm. These are her clinical and radiographic photos. You don't need to be an orthopedic surgeon to recognize we have a problem here. If you look at the clinical picture, you can already see there's puckering of the skin, bruising and ecchymosis related to the gross deformity of the arm from the displaced supracondylar fracture. If you remember back to your anatomy, the structures that sit right across here on the anterior part of the arm include the brachial artery and the median nerve, which are often at significant risk when there's been such a tremendous displaced fracture. This is a surgical emergency. So supracondylar fractures, when they're grossly displaced, are easy to diagnose. However, when they're non-displaced, they can be quite subtle. There's often no bony abnormality. The key hallmarks are a child falling with their arm extended. And what you are looking at on this x-ray here with the arrows are what's called the fat pad signs. So there are usually in most people an anterior fat pad. However, in the setting of a fracture where bones are fairly vascularized, the break of the bone creates bleeding in the joint around the elbow. That causes elevation of the anterior fat pad and presence of a posterior fat pad. And the visible posterior fat pad is always pathognomonic of significant trauma to the elbow. So even if you don't see a fracture but you see a posterior fat pad, your suspicion for a fracture should be quite high. And when we think about supracondylar fractures, there's really 3 types. So on the far side here is a type 1 supracondylar fracture, and this is a great view of the anterior fat pad, which is elevated, and it kind of looks like the sail on a boat, and it's called the sail sign. And then you also see the presence of a posterior fat pad here, which is not normally present. A supracondylar type 1 fracture is one that just has a crack, but you hardly can see it, and there's really no displacement. A type 2 fracture like this one, you can see that there's a line that goes straight across, and if you look, the humerus is extended ever so slightly, tipped back. A type 3 is, of course, the worst type, where there's 100% displacement of the 2 pieces of bone relative to the fracture. Type 3 fractures are surgical emergencies and need to be treated urgently. Supracondylar fractures are the most common fracture around the elbow in children. The common age that it occurs is between 3 and 10, and the mechanism is usually related to pretending to be a monkey on the monkey bars. And the children fall off the monkey bars, they put their arm out behind them, and they hyperextend their elbow. And if you can remember back to the x-ray where we showed you on the lateral view, the supracondylar area is a thin piece of bone and it's the weakest area. And that's where the force is focused to, and that's where the fracture occurs. Associated with supracondylar fractures, there's a high risk of residual deformity. There's a great potential for neurovascular compromise in the setting of displaced fractures. And displaced fractures require urgent referral. Splint and send the child somewhere where they can be treated. Don't try and do any manipulations or any other treatment at your institution. Send them somewhere where they can be treated urgently. So throughout the talk, we're going to have these clinical pearls. This clinical pearl is called physical exam for fracture. Some of this may be fairly obvious to you, but fractures are associated with swelling and decreased motion. This is supposed to be, not a news up flash, but essentially fractures are associated with swelling. And so even if a radiologist says they think they see a fracture, if clinically the child has no swelling, the likelihood of a fracture is low. Most healthy children do not break their bones without trauma. So the keys are looking for swelling, looking for decreased motion, hone up on your physical exam skills. Touch and move everything. And when I examine a child, I start in the areas that are least painful and slowly work towards the area of maximal tenderness. This will help me in my interpretation of the radiographs and also in my clinical diagnosis. If something is really swollen and you can't see a fracture, be concerned. Be suspicious of a dislocation, a cartilaginous fracture, or something else is going on, and send that person to be seen by somebody who knows what they're doing with respect to fracture management. It's important to recognize that young children rarely sprain their ankles or their elbows or their wrists. We as adults have sprains and strains quite frequently. Children, on the other hand, tend to break before they sprain. And the reason for this is they fail through one of their growth plates. The growth plate is the weakest area. Their ligaments are much stronger than the growth plate, and that's why it's less common for a child to have a sprain or a strain. It's much more common for them to have an undisplaced fracture. And this phenomenon exists in particular in children under 6 years of age. And finally, always think about infection. In particular, when you're seeing a child who has swelling and pain and decreased motion with not a very clear history of fracture. So this is my first clinical Pearl slide. Now, we'll go back to our first case of the upper extremity pain. This is a 3-year-old boy who's fallen on an outstretched arm. And you can appreciate from this clinical picture there's a lot of swelling on the lateral aspect of the arm. He's able to move it, but it has a lot of pain. And when you touch over that area, you can appreciate swelling and discomfort. This is a lateral condyle, or what I would call a snake in the grass. Lateral condylar fractures are tricky to identify. If you look here on this slide, there's an arrow that's showing you just a little wafer of bone that's just fractured. It's very subtle, and it's not present on all the X-ray views. And if you think a child has a lateral condyle fracture, it's important to get oblique X-rays of the elbow so that you can see if a fracture exists. Lateral condyle fractures are different than supracondylar fractures. First of all, they're second in terms of their frequency, but the most important feature is that they're an intra-articular fracture. And the significance of an intra-articular fracture is, one, it needs to be pretty well aligned, because if there's articular incongruity, that leads to arthritis down the road. And two, because it's an intra-articular fracture, it's bathed in synovial fluid. And as a result of that, it takes much longer for the fracture to heal. A common supracondylar fracture will only be casted for 3 to 4 weeks, whereas a lateral condyle fracture will require casting for upwards of 6 to 8 weeks so that the fracture heals appropriately. And as a result of that, this fracture has a greater propensity for late displacement because it's not recognized, and people will take the child out of the cast at 3 weeks and the fracture will then displace. Be suspicious of a lateral condyle when you see a significant amount of bruising on the lateral side, even if you can't identify a fracture. Clinical Pearl number 2 is going over the ossification centers around the elbow. And when you think about these, you can think about the acronym CRITOE, which stands for capitellum, which is here, radial head, which is here, internal epicondyle, which is here, trochlea, olecranon, and external epicondyle. And the beauty of this is that this tells you when these ossification centers form. And down here you can see there's a slight difference between girls and boys just based on skeletal maturity, but they start either at age 1 or 2, and every 2 years a new ossification center forms. The significance of this is that when you're looking at an X-ray and you know the age of the child, go through this ossification algorithm in your head and look for the associated ossification centers. If one is missing and you think it should be there, have a great suspicion that something has happened to that ossification center associated with the fracture. The most common injury that you can think about is injuries to the internal epicondyle, where often in an elbow dislocation, this structure can be pulled off and sometimes it sits in the joint. And so if you're looking at a 12-year-old and you don't see the internal epicondyle and you know it should be there, have a great suspicion in the setting of a swollen arm that something has happened to that structure. So our third case for the upper extremity is a 6-year-old girl who's fallen on her outstretched arm after falling off of a swing. And here's her x-ray, and you can see here to the astute eye that there's a fracture to the ulna. And the classic misconception or error is to focus just on this fracture and treat this in a cast. But if you look more carefully at the whole x-ray and it's been cut off appropriately, the radial head doesn't look right. And if you look at some newer pictures, you can see that the radial head does not line up with the capitellum. And this is a radial head dislocation, or a Monteggia. This is another snake in the grass, one of the more commonly missed injuries both for pediatricians, emergency docs, as well as pediatric orthopedic surgeons. This, once it's missed, can be a terrible problem for the child and can be very hard to make right. So clinical pearl number 3, when you're looking at the elbow, these are the key lines that you need to draw. So the anterior humeral line is a line along the front of the elbow. And on a true lateral with the elbow at 90 degrees, this anterior humeral line should cross through the capitellum around the middle third. And if it doesn't, there's either a fracture here or a problem at the capitellum. The second pearl is the radiocapitellar line, which is the line between the radius and the capitellum. On all views should bisect each other. When you draw a line along the radius, it should always bisect the capitellum. And if it is not bisecting the capitellum, you should be suspicious for a Monteggia fracture. So going back to the x-rays that we talked about, you can see as we draw a line along the radius, in all views, it's not bisecting the capitellum on any of the views. So this is an anterior Monteggia fracture related to, most of the time, a minimally or maximally displaced ulna fracture, as seen here in this cartoon. If we look at all of these activities here, they all can most likely result in what? The common nursemaid's elbow. And the nursemaid's elbow is fairly commonly seen in the pediatrician's office. It happens between the ages of 1 and 3, and it's usually a traumatic subluxation of the radial head due to a sudden traction on the hand with the elbow extended. Most parents aren't going to say my child's elbow was extended with the arm pronated. They're going to just tell you, based on the history, the child was walking out of the street and I yanked them back or jerked them very suddenly, and all of a sudden they started to have pain. And what happens is when you pull the arm abruptly, the radial head subluxates out, and the annular ligament, which wraps around the radial head, gets interposed and stuck in a wrong position. So the clinical presentation is the child will have sudden onset of pain and refusal to use the arm. They'll hold the arm in slight flexion with some pronation at their side. And usually the radiographic features are normal. So really your diagnosis is made based on history and clinical exam. If from the history you hear from the parents that they were yanked or jerked quickly and then they had pain, it's a nursemaid's elbow until proven otherwise. However, if you hear that they maybe had a fall, you're not sure, then your suspicion for nursemaid's elbow should decrease and you should work them up for a fracture. Often when I'm seeing a possible nursemaid's elbow, the radiographs are not particularly helpful. And if I see, based on the history, that it seems consistent with a nursemaid's elbow, I won't do any x-rays. The treatment to fix this is a maneuver by flexing the arm and supinating the arm in the flexed position. Now, what I would tell you is you have one shot to make this right. So before you go ahead and do this, I would talk to the parents about everything that you're going to do, explain to them what you think is going on, and then answer all their questions, and then try to do the maneuver. Because you can sneak up on the child pretty easily once, and after that, they'll fight you, and the fighting makes it very difficult. The other common pearl is that Most typically, reducing a nursemaid's elbow is in maximal flexion and supination. But if, when you're doing that and you have your hand on the radial head and you don't feel a reduction, then take the arm and pronate it fully and bring the arm into extension and supinate it and go through a full arc like this one or several times. And eventually you will feel a click that is quite satisfying, and that's reduction of the nursemaid's elbow. It's important to talk about the Seymour's fracture when we're talking about upper extremity emergencies, because this is another one that you need to identify. What happens here is you have a fracture through the tuft. It's often the finger gets caught in a door, it's a nail blade injury, and what you need to recognize is the physeal fracture of the distal phalanx has an associated nail bed laceration, and the nail bed goes into the fracture and stays between the two fractured fragments. The problem with that is it's a great risk for infection. So if you suspect that someone has a Seymour's fracture based on these x-rays, what you need to do is remove the nail, irrigate, debride the fracture, do a proper nail bed repair, and reduce the fracture. And it's important when we're talking about nail bed repairs that when you take the nail off and you want to replace it, whether you do it with a nail or whether you use Xeroform or some tin foil, that piece needs to sit deep into the nail fold. The nail fold extends much past what you can see, and often you need to make a slit on either side to open it up. But you need to stick something in there to keep it stented open. If it heals together, the nail will grow in a very awkward shape and cause disfigurement for the patient. So the goal is to try and splint that open, and that's where we use the nail to put it back in, or tin foil or some other inert substance just as a splint, and that splint is really only necessary for 5 days. So as we go to clinical scenario number 2, the toddler or child presenting with a limp or refusal to weight bear. The diagnosis is fairly broad, but I think if you break it down, you need to think about infection, trauma, and inflammation, and that's what we're going to talk about. So, this is a 4-year-old boy with a 3-week history of worsening limp, intermittent fever, and runny nose. As you can see here on the initial x-rays, it's somewhat benign, but if you look carefully, perhaps maybe with the eye of faith, you can see a little bit of area of increased lucency right here. And on the lateral, it does look like there's a fair amount of inflammation based on the stranding of the shadows. The child goes home, still has persistent limp, comes back 2 weeks later, and those areas of concern are much more detailed here. And this really is a Brodie's abscess or osteomyelitis. Osteomyelitis is quite common in children, in particular in younger children under the age of 5. You need to have a great suspicion for this, in particular in metaphyseal bone areas that are adjacent to the physis. With respect to infection, the physis is actually a very good barrier, but the area right next to that is quite at risk for infection. And what can happen is you need to have a great suspicion of osteomyelitis in concert with septic arthritis in these 4 locations of the proximal femur, the proximal humerus, the distal tibia, and the radius. And the reason why is because in these areas, the metaphysis is intra-articular. And so if there's an infection in the metaphysis, it can break out and seed the joint. So elbow, shoulder, hip, ankle, all can present with osteomyelitis and associated septic arthritis. So how do you make the diagnosis? Well, primarily it's made by history and physical with the help of labs. So most children with osteomyelitis will present with localizing symptoms of pain in a particular discrete area where there's either redness, swelling, or pain to touch. They'll be systemically unwell. They'll have a fever, they won't feel right, they won't be eating, they may have some malaise. They may not use that particular upper extremity, or they won't weight bear. And it's, as I said before, it's quite common in younger children. So the workup would involve a differential, a CBC with a diff, an erythrocyte sedimentation rate, and a C-reactive protein, as well as blood cultures. Now, all of those are useful, but the C-reactive protein is the most helpful to guide clinical resolution because it will rise at 6 hours, it peaks at around 48 hours, and then falls the fastest, while as ESR will trend and stay up for quite some time. So when we're following a child to see how they're doing, we'll look at their fever trend and their CRP to trend if we're making an improvement in treating their osteomyelitis. So parents will always say, why did they get this? How come my child got an infection? And it's really related to the pathophysiology of the blood hematogenous spread. There are vascular loops which occur at the metaphysis, and this results in slow or sluggish blood supply around the metaphyseal area in young children. That slow blood supply allows bacteria to hop off or out of the circulation and into bone. And what happens is they set up in the metaphyseal bone, they start to have resorption in about 12 to 18 hours, and then they form pus. And the pus will break through the cortex and form an abscess. And if it's in one of those areas that we talked about before, it will form a septic arthritis. Now, the cortex that's underlying this area doesn't have periosteal blood supply and will die. And that's what's called the sequestrum. But the periosteum around it is still healthy and alive. So it will make new bone, which is called the involucrum, which covers over the sequestrum. And the sequestrum is the perfect area for bacteria to hide because there's no blood supply to it. Now, osteomyelitis in neonates is a special problem, and it's a very dangerous problem that you need to be very vigilant about, because before the ossific nucleus appears, which is what happens in neonates, the metaphyseal vessels penetrate directly into the epiphysis. So it's much more common for a bacterial infection of the bone to seed a joint. And because a neonate is nonverbal often, it's hard to identify an infection. And often a delay in infection occurs with significant morbidity. So the goal is to try and have a high suspicion for this in a neonate who's septic or febrile and identify it in a timely fashion. The general treatment of osteomyelitis really depends on how quickly you identify it. If you identify it quickly, usually acutely IV antibiotics with a combination of oral antibiotics for 3 weeks is enough. If it's more chronic, it takes 6 to 8 weeks to resolve. If you've treated someone appropriately with IV antibiotics and you see no improvement, consider doing an MRI after about 48 hours to suspect an abscess or other problem going on. And most abscesses require either drainage by interventional radiology or formal surgical debridement. The second case in the limp is a 6-year-old child with left hip pain for 3 days with no history of trauma. And this really is to try and differentiate for you septic arthritis versus toxic synovitis, which I'm sure is the bane of most pediatricians and family physicians, as well as orthopedic surgeons. Again, the history and exam are key in terms of helping differentiate what's going on here. Most children will present with hip or groin pain. They may have knee symptoms. Usually there's a recurrent illness a couple weeks before, upper respiratory tract infection. They'll have refusal to weight bear, plus or minus a history of fever. A child will hold their leg if they truly have an effusion, like this child right here. Their leg is flexed and externally rotated and abducted, and that's the position which decreases the pressure on the hip joint. Because of the effusion, the pressure in the hip joint causes them pain. The child will not want to weight bear and will not let you move the child's hip around. And probably the best way to simply test a child's hip range of motion is what's called a log roll test, where you just gently take their knee and roll it from side to side. You'll get a sense of if a child is guarding and not letting you do this. And be aware that in young children under 4, you can easily overpower their clinical exam. So if there's any guarding, that should be a concerning feature for you. And similar to osteomyelitis, the lab work is the same. A CBC with differential ESR, C-reactive protein are the hallmarks. In particular in our area here, probably drawing a Lyme is also the standard of care. So these are the X-ray and ultrasound of this patient who's presenting with a 3-day history of limp. And when you look at the X-ray, it's really hard when you're trying to diagnose a hip joint effusion to see anything on X-ray. There's maybe a little bit of asymmetry here between this side and this side, but it's very subtle. And most of the time an effusion is negative on X-rays. But the ultrasound is your money test. You can really see a difference. Usually in most centers an ultrasound will be done on both the right and left side, and what you're looking for is a difference. So this is the contour here of the hip, this is the growth plate here, these are the muscles of your abductor, and this is the joint. So this black area here is the fluid. So you can see here there's more fluid here. This is the normal joint here. And so you can see some thickening also over here of the synovium as well. And the asymmetry gives you your clue. So usually if you see an effusion and you're concerned, the next test in terms of help guiding you is an ultrasound-guided aspiration. And we send this for cell count, gram stain, Lyme titer, and what we're really looking for is our white blood cell count and our gram stain. A white blood cell count generally under 25,000 is considered inflammatory and benign, but over 75,000 is infection. And the gray area is between 25 and 75, where it's hard to differentiate, and that's where you put all the pieces together to try and decide whether or not this is truly transient synovitis, Lyme, or septic arthritis from a bacterial source. So making the decision for septic arthritis, it's really important to think about these 4 primary observations. And this is probably one of the more important slides that you can take away from this talk. So refusal to weight bear, history of fever greater than 38.5, a white blood cell count greater than 12,000, and an ESR greater than 40. These are what are called Coker's criteria. And if you look at those criteria together in concert, retrospectively, all 4 factors present gave you a 99% positive predictive value of septic arthritis. Coker further looked at prospectively what would happen, and still, with all 4 of the criteria, you have about a 93% positive risk of septic arthritis. Now, others have not been able to reproduce the high numbers, but clearly these 4 observations are critical to guiding your treatment and therapy. So treatment for septic arthritis is an emergency. We believe that an infection inside the joint will eat away at cartilage, and the only way to treat that is to start antibiotics and to wash the joint out. And often you may need to wash the joint out multiple times. The treatment for septic arthritis is not just IV antibiotics. Sometimes, in unique scenarios of neonates who are quite sick, you can irrigate the joint with large needles, one on either side if the joint is relatively small, and flush fluid through to clear out the joint. But the majority of these are washed out in the emergency room. And finally, a word on transient synovitis, which is probably the #1 cause of pediatric joint pain, not including trauma and infection. This is related to an inflammation of the synovium, which is nonspecific. It's usually related to a viral illness. An effusion does develop, which causes pain and stiffness. And the clinical presentation here is just a little bit milder than a true septic arthritis. They have a limp, their joint is irritable, but they're trying to limp around on it. They may have had a viral prodrome 2 to 3 weeks previous, but they're not toxic in appearance, and usually their inflammatory markers may be slightly elevated, but their white count is not significantly elevated. And the key is, if you think a child has transient synovitis, you must watch them carefully. You must rule out septic arthritis, and you activity restrict them with nonsteroidal anti-inflammatories. Finally, a word on Lyme arthritis when we're talking about septic hips. It's very common in this area of the Northeast. It's related to a spirochete infection and often is associated with a rash, at least in the textbooks, but in clinical practice, most people who have Lyme don't appreciate having a rash. It can cause arthritis, but that arthritis can happen anywhere in 60% of the time up to a year after the initial bite. And so most people don't associate the bite with the arthritis, and this is primarily the most common cause of a swollen knee in an asymptomatic child in my clinic. The treatment usually is to rule it out by doing a Lyme antibody or joint aspiration, and often antibiotics alone, managed by the primary care physician, is enough to treat Lyme arthritis. Rarely do we treat them in the operating room. Clinical pearl number 4, other causes of limp. So limp is not normal in a child. First, though, when you're getting the history from a parent, make sure that their limp is what you think limp is, as terms can be very different. Consider the things we've talked about, as well as other causes for limp: discitis, osteoid osteoma, which is nighttime pain primarily relieved by NSAIDs, leukemia, and other metabolic bone diseases can also cause limp. So have your spidey senses tingling when you see a child limping in your clinic. And finally, to round out the limp, this is a young girl who is limping after going down a slide or jumping off a chair. Going down a slide, the common scenario is two people are going down the slide. There's a younger child and a heavier child or a parent, and the younger child's leg gets stuck against the side of the slide and they have a twist, and they result in the toddler's fracture. They won't weight bear, they have pain somewhere in their lower leg, and their x-rays are usually negative. The best way to test for a toddler's fracture is to take the child's knee and the ankle and twist their leg. The twisting motion is what reproduces the fracture, and it's often hard with point palpation to localize the pain. So on the x-rays here, it's pretty negative. On the follow-up 3 weeks later, you can see some increased periosteal reaction here and some sclerosis. The similar picture to a toddler's fracture is a child who's either jumping off a chair or has been running around, and they have what's called a Kohler's fracture, which is fairly hard to appreciate, but if we zoom in here, you see some increased sclerosis in the cuboid. So toddlers and Kohler's fractures are very common, mostly in young children between the ages of 2 and 4. The injury mechanism is often minor, and it's really like a stress reaction. It's not a high-risk abuse injury pattern, and it's usually something that will get better by itself. Most of these kids will limp for a couple weeks, and if they don't keep pounding on their leg, they will get better all by themselves. Often we'll put them in a cast or a boot to limit their symptoms and prevent them from getting any worse, but these often are fairly self-limiting. So, moving on. Clinical scenarios. This is the child and adolescent with hip pain. This is an 11-year-old girl with a 1-month history of right-sided groin pain. And her primary care physician has said that they have a groin pull. This is another snake in the grass. Most kids do not get groin pulls. What you have to recognize here is that this is slipped capital femoral epiphysis. And if you look here at the growth plate, there is this fluffy appearance here to the physis compared to the other side. And what's happening here is the physis is slipping. The analogy to think about is it's an ice cream on a cone, and the ice cream part is falling off of the cone. And the way to look at it is what's called Klein's line, which on an AP pelvis, you draw a straight line up the neck, and it should capture just a little bit of the femoral head. Whereas on this side, you can see the ice cream cone has fallen off already, the ice cream. This is a problem. Slip capital femoral epiphysis happens slightly more in males than females. There's a high risk of having a recurrent slip on the other side, and that risk is really directly related to the age of the first slip. The risk factors are obesity, renal failure, and endocrine abnormalities. And it seems to be a fracture through the hypertrophic zone of the physis. And the problem is the clinical features are fairly subtle. Limp, dull pain, and then eventually it gets much worse and they have inability to weight bear. So the diagnosis is challenging. The primary issue for you is to make the diagnosis and identify those kids who have a pre-slip condition before they fall off and before their ice cream cone falls on the floor. So when you think about the symptoms, most kids will have some sort of groin pain, but almost a quarter will have knee pain only. So think about the knee pain relating to the joint above when a child presents with knee pain. The management is usually putting a screw in situ to try and prevent that hip from sliding back. Some of the newer methods involve dislocating the hip, shaving the hip down, and putting it back so that we put the ice cream back on the ice cream cone. So clinical pearl number 5, knee pain is hip pathology until otherwise proven. So most young children endorse knee pain when they have hip pathology, and the reason for that is because of the saphenous branch of the femoral nerve runs down the anterior part of the hip and the medial aspect of the leg. And so they'll say they'll have pain because of swelling over their joint, which is irritating the saphenous nerve. Children and adolescents rarely get groin pulls. So aching pain that doesn't get better with rest is a skiffy until proven otherwise. Always think about the joint above and below the complaint. And a knee effusion in a child has pathology. So if you see a knee effusion in a child, have a low threshold to order an MRI. Moving on, the child and adolescent with knee pain. The differential here is quite broad. There can be an acute injury such as a fracture, and this picture on the side here is showing you a tibial tubercle fracture where the tibial tubercle has popped up. This is classic in an adolescent male who's going up for a slam dunk. It's a basketball jumping related phenomenon. They jump up and the force of their quadriceps to make the jump basically pulls the bone apart because the growth plate is just closing right here. But when it's tipped up like this is a surgical emergency. This is pushing on the skin here, and the skin will die unless this is fixed urgently. Other less acute issues are overuse phenomenon such as Osgood-Schlatter's, Sinding-Larsen-Johansson, and osteochondral lesions. You always have to think about neoplasm and osteosarcoma. And finally, there's growing pain and secondary pathology. So this is a 13-year-old male who comes in with right knee pain for several weeks. There's been no history of trauma. Here are the x-rays that you order in your clinic. Now, you don't have to be a radiologist to appreciate that these x-rays are bad. This is bad prognosis. What you see here is there's a lesion on the outside part of his knee, the borders of which are very ill-defined. You can see up here, but then here it's hard to know where it comes through. And you can see here there's a large soft tissue lesion. An MRI will show you that this is also very bad. It goes through, there's a large soft tissue mass, goes through the joint, almost and into the joint. This is osteosarcoma. It's an eccentric lesion along the metaphysis. It's aggressive, destructive. You see these things called Codman's triangle, or a sunburst appearance where the periosteum is standing on edge, and that's related to the aggressivity of the tumor. This is the most common malignant bone tumor in children and adolescents. It's common in males more than females, and it seems to be in the metaphysis of the long bones, primarily around the knee, in the distal femur, proximal tibia, or proximal humerus. Children will present with localized pain that's intermittent, constant, and severe. They'll have decreased motion, antalgia, sometimes they'll have a mass, but they won't really be sick in appearance yet. They'll have elevated inflammatory markers, ALK Phos, and LDH if you're going to do a test for them. This is a picture of Terry Fox, a proud Canadian who had osteosarcoma, and he did his Marathon of Hope, where he tried to go from one end of Canada to the other to raise money for cancer. Unfortunately, he had recurrence of his osteosarcoma during that, and he had to stop early. The workup, though, when you're thinking about osteosarcoma, involves plain x-rays, MRI, and then you do a bone scan and a CT scan to look for malignancies elsewhere. The treatment is surgery and chemotherapy. In the past, it was just amputation, and that's probably why Terry Fox died. Right now, we have much more adjuvant therapies that are helpful in terms of chemotherapy first, surgery second, and that seems to improve the longevity of osteosarcoma in our children. So another case is a 13-year-old boy with a 1-year history of bilateral anterior knee pain, worse with running and jumping. Here are his x-rays. He's otherwise constitutionally well. And if you focus on these x-rays in the inferior aspect of the patella here, you can see there's a little fleck of bone. There was not one discrete traumatic episode. So this is Sinding-Larsen-Johansson Disease. It's essentially an overuse traction injury that happens in adolescence. It's related to the patella tendon pulling on the inferior pole of the patella, causing fragmentation at the inferior pole. It has some soft tissue edema, and it's one of those nagging type injuries where it's worse after a child or an adolescent does activity, but doesn't stop them from doing that activity. The general management for it is activity modification, ice, and nonsteroidal anti-inflammatories. The sister disease to Sinding-Larsen is Osgood-Schlatter, where instead of happening on the inferior pole of the patella, it's now on the tibial tubercle. It's another overuse condition. It's common in the same age group, and sometimes you can even see fragmentation of the tibial tubercle. Really, in my clinic, this is a clinical diagnosis. Children will have discrete pain over their tibial tubercle. They'll have difficulty doing a straight leg raise. If you see that, think Osgood-Schlatter's disease. A 15-year-old female soccer athlete, right knee pain, no history of injury. She plays a lot of soccer, 6 or 7 times a week. Here are her x-rays. The AP x-ray looks pretty benign. There's nothing really to see. As you start to look on the lateral and the tunnel view, the plot thickens. This is another snake in the grass, the osteochondral lesion. The arrow illustrates the area here that's not normal. Osteochondral lesions, as seen on the MRI, are areas of fracture related to repetitive use but not from a discrete traumatic event. If the fracture is severe enough, you get fluid or edema, as you can see here based on the white, that goes behind the piece, and the piece can actually be free-floating. We believe it's related to repetitive trauma. It seems to be much more common in males than females, and it's really a separation of articular cartilage and subchondral bone. The most common areas, the elbow, the knee, and the ankle. The general treatment is rest. The problem is you may need to rest and limit your activities for 6 months. For most of these children, they are going to be professional athletes according to their parents. And so resting for 6 months is very challenging. Most lose patience and want to have surgery, but surgery is not always the best alternative. The dreaded ankle sprain that comes into everybody's clinic. As we wrap up, let's talk about this. Really, the Ottawa Ankle Rules applies for kids over 6, and so this helps guide you in terms of deciding whether or not you should get an ankle x-ray. Tenderness over the lateral aspect of the ankle or over the medial aspect of the ankle, and inability to weight bear 4 steps. If a child has any one of these, they should get an x-ray. If they don't have any of these, don't bother doing the x-ray. For every 1,000 patients that exhibit negative Ottawa Ankle Rules, only 14 will actually have a fracture. So this is a very good test. It becomes more challenging in younger children or those who are not particularly articulate and verbal. But this should help guide you in terms of what to do with the sprained ankle. And finally, fractures around the ankle. The most common are these transitional fractures called the TLO or the tripane fracture. Pardon me. These fractures occur as a growth plate is closing in adolescence, and what tends to happen is this gets pulled. It's essentially an ankle sprain, but the ankle sprain fractures instead of spraining because the physis is weak. Often, these are Salter-Harris 3 fractures if they involve the joint surface and require surgery if greater than 2 millimeters of displacement to prevent the risk of arthritis. So to summarize, fractures are associated with pain and swelling. If you're unsure of what you're looking at, you can always x-ray the opposite arm. Always consider infection when a child presents to your clinic with inability to use a limb and swelling. Remember Coker's criteria for the infected hip to help guide you in terms of deciding whether this is a transient synovitis or a septic arthritis. When you're examining joints, always think about going above and below, and children break before they